what are the various causes, fails, and pitfalls of the
case scenario. First case is a 10 years old boy presented with classroom, and this is a pre-operative this is the picture exercise and with so problems in the long-term outcome, and the estimated incidence of hydrocephalus with epilepsy has been reported as much higher in children who are treated by shunting than in those who are not treated, as using BP shunt. And there are many factors that influence the prevalence of epilepsy. These include etiology of hydrocephalus, is the diagnosis of hydrocephalus or the shunt placement, intracranial pressure, site of borehole in cases of the BP shunt, number of revisions in post-shunt patients, time course of a shunt insertion, use of antiepileptic agents, and complications such as infection and shunt tube obstruction. So there are many reports in which these issues have been extensively discussed, but the results are still diverse and they remain controversial in every aspect. So age at the time of initial shunt placement is an important factor, and early shunting is a well-known determinant of risk in shunt obstruction. And children less than 2 years old are consequently at a higher risk of developing epilepsy than the older ones. It is reported that the antiepileptic drug treatment is not so reliable as might be expected, and the incidence of seizure post-shunt is reported to be quite high, ranging from approximately 20 to around 50%. These are the various disorders related to the series of abnormalities which may present as a seizure or epilepsy, such as obstructive hydrocephalus, overproduction hydrocephalus, normal pressure hydrocephalus, idiopathic intracranial hypertension, stunted hydrocephalus, or the post-meningitic hydrocephalus and ventriculitis. So these are some of papers which have mentioned the relation between the association between epilepsy and hydrocephalus. This first is the paper is published in 1995, and this paper described the essential epilepsy with hydrocephalus. And in this paper, the CSF diverted by using the shunt in 464 patients, and the median follow-up period was around 6 months. And the prevalence of the EED treatment at diagnosis hydrocephalus was 12%, that is in 56 of the patients. And 10 years for the diagnosis, it was around 33%, which rise quite significantly. And patients who required more than 4 shunting operation needed slightly less AD treatment, but this finding was not statistically significant. Continuing this with the same study, in that sees the 309 patients exclusively frontal boreholes, and the 71 patients exclusively parietal boreholes, and the 50 were treated for 1 or more shunt infection during the follow-up period. And in this study, they found the post-traumatic and post-meningitic hydrocephalus to the highest prevalence of epilepsy. And they also conclude that the borehole site is often discussed in relation to the seizure prevalence in the post-shunt patient, but the site demonstrated no little effect on the prevalence of AD treatment in this study. Similarly, another study published in 1999. In this, there is a study on 197 shunted hydrocephalic children to see the association between the shunted hydrocephalus and development of epileptic seizures. And of the 197 patients, 119 had obstructive hydrocephalus. And the mean age of the child at the first shunt insertion was 1.5 years. And the myelomeningocele was the most common cause hydrocephalus in this study, that is around 45%. And of the total patients, around 17%, that is around 34, had at least a single episode of epilepsy seizure. And of these 34, around 13 patients had only a single episode, and 21 patients developed multiple seizures. And the mean age of first seizure was 1.35 years, and 51% of the patients who developed seizures had the first seizure during the first year of life. Similarly, another paper published in 1996, they studied in a cohort of 817 shunted hydrocephalic children. And among these, 311 patients with the shunt had seizures, and there was a significant difference in seizure incidence among the diagnostic group. And the first seizure occurred at a median of 1.6 years after original shunt insertion. And they found that the prevalence of posterior seizures by the sides of ventral axis was not significantly different. So they actually compared with like post-meningitic, hemorrhagic. So in this case, they found no such significant differences. And authors conclude that the shunt do cause epilepsy, but underlying abnormalities of the brain are more important in determining whether or not the child develops epilepsy. Similarly, this is the other paper from 1998, in which they had found that 182 patients had undergone initial shunting. And in this series, around 37 epilepsy diagnosed in around 37 of the children, and 25 children had a symptomatic one episode seizure. And they found that the patients with epilepsy had shunting surgery much earlier than patients without the epilepsy, regardless of the etiology. And incidence of epilepsy was high in the patient post-hemorrhagic and post-infectious hydrocephalus. And they found that patients with multiple shunt revisions failed to show any increase in prevalence of epilepsy, and borrowal sites made no difference. So coming to this, now we can see that in many papers they have mentioned that following the shunt, there is a more instance of seizure as compared to pre-shunt. So there have been recent studies on ETV as alternative for the VP shunt to decrease the prevalence of epilepsy following the surgery. So this is a paper which was published in 2001, and they found that patients with VP shunt present with various complications, appearance of seizures over time. And this is a study from 1996 to 1998, in which the 42 patients underwent ETV and 27 operated children. So after exclusion, there were 27 children, and they followed an average of 32 months and not experienced seizure during that time. Similarly, another paper published in 2018, where there was 118 infants were enrolled between 2014 to 2015. And of these 118, 113 patients, they met the criteria. And the most common posterior complication was a seizure, which is seen in about 6 patients. There's a 5.1%. So this is very less as compared to the previous papers, which mentioned around 20 to 30%. And similarly, a randomized control trial was done in 2010, in which, however, they did not find any difference in the prevalence seizure following either ETV or the VP shunt. And patients they randomized to ETV had incidence at 9.4 seizures per 100% a year, whereas those who were randomized to VP shunt had an incidence of 9.5 seizures per 100% years. So come to our experience, around 38 patients in the last 1 year. So we had a complete data from 38 patients who present with hydrocephalus. And of these 5 patients, they had seizure as well. And of these 5 patients, we placed a shunt in 2 patients and immense EVD placement in 1 patient. And all these patients at present, they are seizure free and they are currently on EED. So to conclude my presentation, hydrocephalus presenting a seizure rare occurrence, especially in adults, and across literature has seen that the intervention, mostly VP shunt, has more tendency to cause seizures, and ETV is being seen as a better alternative in preventing seizure in shunted hydrocephalus. Thank you.
Thank you, Sandeep, for your nice presentations. And now we call upon another speaker, Vivesh Patel. He will be talking about the seizure related with the infection.
Good afternoon, everybody. I would like to continue today's talk with my presentation, epilepsy in infection. Namaste, I'm Dr. Vivesh Patel, and I'll be starting my presentation with a video of a case. This is a 45-year-old female with multiple episodes of seizures since 1 month, and it was not relieved by anti-epileptics. EEG performed showed seizure lateralized to the left side, and MRI done showed left temporal lobe cyst, which was excised as shown in this video. Patient is seizure-free with anti-epileptics since the removal of the cyst. Now coming to the interaction of the infectious agent and the central nervous system. There are various infectious agents, and because of this, when it reaches the CNS through various physiological mechanisms, it creates a pathogen-mediated effects as well as a host response-mediated effects, and all of those give central nervous system manifestations or symptoms. But today's talk is on epilepsy, which is also one of the complications of the manifestations. Okay, coming to epilepsy, the lifetime prevalence of epilepsy is around 1.5 to 14 per 1,000 population, which was a study done in 2007 in 23 Asian countries, including Nepal. And the commonest etiology worldwide is infectious, especially in developing countries like ours. And the infection of CNS can cause acute symptomatic seizures as well as epilepsy. And 5% of patients with CNS infections are present with seizure. So if we can prevent these infections, the epilepsy burden can be reduced as well. Now coming to the various etiologies of CNS infections, it can be characterized as bacterial, parasites, fungal, as well as viral. There are lots of other reasons for CNS infections, but these all are the most common type that can be present in, especially in our part of the continent. And I'll be talking about some of those as well. Okay, now this table, this is a table I've made taking all the presentation of infective seizure in Nepal. And in various study, the NCC ranged from around 5.3% to up to 46.2%, while that tuberculoma was 3.8 to 4%. And in a study, the meningitis was in 10% of the population as well. So I'll go into the individual topic. Firstly, the bacterial infections. It involves the meninges and the cerebral parenchyma, and most of the CNS bacteria infection causes acute symptomatic seizures. The route is via the hematogenous spread, direct invasion through the trauma or cranial sinuses. And for a seizure to occur, the bacteria has to reach or damage the cerebral cortex. So, and the treatment of seizure is the same as other thing, and it follows the same principle to give anti-epileptics. Okay, now firstly, the bacterial meningitis. Acute symptomatic seizure occurs in 4 of this most common bacteria, and it ranges from 10% in meningitis to almost 78% in beta hemolytic streptococcus infections. And acute seizure is caused in case of bacterial meningitis because of fever, subdural collection, cerebritis, or cerebral infarction. So how does a seizure occur? The bacteria colonizes the subarachnoid space, and it produces a purulent exudate, and plus the toxins they produce, it creates an inflammatory reaction, and because of that, acute seizure and even late epilepsy can occur. In case of late seizure, in case of bacterial meningitis, normally it's focal characteristics with which are often drug resistant. Now the other one is the intracranial abscess. The brain abscess causes acute symptomatic seizure, and the presenting symptom, that is the early seizure, is seen in around 25% of all the cases. So the cerebral abscess can be seconded to a predisposing factor like sinusitis, otitis media, dental abscess, congenital heart disease. The agents, mostly 50% of them are anaerobic bacteria. The remaining can be aerobic or a mix of both of those. And abscesses, they create a localized encephalitis as well as arthritis. As you can see in this picture, this is a frontal lobe abscess with purulent central necrosis and ill-defined hemorrhagic encephalitis. So because of that, what happens is it triggers an inflammatory process and it results in acute seizures. And when there is a abscess, we drain it surgically. Because of that, glass occurs. Because of that also can be a risk factor for late seizures as well. The other one, intracranial empyema. The most common source for intracranial empyemas are middle ear, meningitis, as well as paranasal sinus. The purulent material accumulate in the subdural and epidural space that distance the dura and cause thrombosis. And because of that, there is a localized encephalitis and arthritis. And because of that, the seizure occurs. So, and seizures in case of empyema are more in acute phase, and only 1/3 late seizure occurs, and those seizures are often drug resistant. Again, the treatment is the surgical drainage of empyema. CNS tuberculosis, almost 20% of the people with CNS TB develop seizures. Mycobacterium tuberculosis is the organism, and it reaches the brain by the hematogenous spread from the lungs, because of which subacute meningitis or intraparenchymal tuberculomas develop, and seizure occurs because of cerebral vasculitis and infarction. and often it's associated with HIV co-infection as well. Now coming to parasitic infections. In case of parasites, the seizure develops because of diffuse encephalitis or intracellular location of the parasites. This table shows different parasite disease that can lead to seizure. But all those things, these are not so much common in our part of the world. So I'll be just talking one or two of those. Firstly, the NCC. As I've already told, NCC accounts for around 5.3 to 48%. So tinea solium is the tinea solium is the parasite that infects it. And in Nepal, the prevalence is around 0.002 to 0.1% in general population. And the epilepsy in endemic areas of NCC accounts for around 30% of seizures. Okay, what happens? The contaminated food with tinea solium, when we ingest that, it goes in the intestine and hatch itself. Then the larva migrate to the CNS and form cyst. And normally there are 4 phases: colloidal, granular, nodular, calcification, and vesicular at the first. So the seizure, normally they occur during the cyst generation, that is the colloidal phase, but normally it can occur at any stage as well. The diagnosis is supportive clinical history, laboratory test and imaging findings. In the neuroimaging, we can see there is an eccentric solex is seen within the cyst. And if the cyst is degenerating, we can see a contrast enhancing lesion with surrounding edema. These are some of the pictures of the NCC. The first one is autopsy, and similar. This is the MRI of a vesicular cyst, which contains a larva of tinea solium in the left lateral ventricle. This figure shows a viable cyst with scolex in the MRI image. This is a viable and degenerative cyst. MRI, as I mentioned, there is a surrounding edema for that. And the last one is a viable cyst with many calcifications seen in CT scan. Coming to cerebral malaria, Plasmodium falciparum is common in sub-Saharan desert for cerebral malaria, while that in Asia, it's Plasmodium vivax. And many epidemiological studies done in Africa has shown that there is a clear association with cerebral malaria and epilepsy. The probable pathological mechanism for seizures are occurrence of vascular lesion, interleukins involved in the inflammatory reaction. In this picture, we can, in this MRI, we can see there is a diffuse petechial hemorrhage which are present throughout the brain, particularly the gray white matter, the corpus callosum, and the internal capsule as well. Third one is the fungal infection. Fungal infection doesn't is uncommon in case of a patient with immunocompetent patients. However, in case of immunocompromised individuals or premature neonates, this fungal infection affects severely. And the fungal agents like Candida, Cryptococcus, Aspergillus, Blastomase, and Histoplasma, all they colonize the CNS, and that's what causes seizures. So the fungal infection of CNS can result in a subacute or chronic basal meningitis, parenchymal abscess, as we can see in this picture, and infarction as well as granuloma formation. Coming to the last one, the viral infections. The viral infections disseminate via blood or the neural pathways, and that infects the brain endothelial cells and released into the parenchyma of the brain. The cytomegalovirus is one of the most commonest fetal viral infection that affects almost 10% of the infants, and those they have early symptoms like microcephaly, anemia, thrombocytopenia, hepatitis, neurological impairment, and sensory neuron hearing loss as well. And in case of HIV, seizure doesn't occur primarily, but it can occur secondary to a neoplastic lesion or with opportunistic CNS infections such as toxoplasmosis, cryptococcal meningitis, and tuberculosis. And in case of encephalitis, the herpes simplex virus type 1 accounts for around 50% of encephalitis, while herpes human virus 6 also is the other leading cause of encephalitis. So to conclude, infectious cause is the commonest etiology worldwide in case of epilepsy. And if we can prevent this infection, we can reduce the burden of epilepsy. Immunization program can help reduce the incidence of epilepsy. Timely diagnosis and treatment is needed for a proper cure, and surgery helps epilepsy control in certain conditions. That's all. Thank you.
Thank you. Vives. Now the next presenter is Professor Amit Thapa. He will talk on fits and falls. Amit, do you exclude the trauma, or are you going to include the trauma in your lecture? What is the plan? The trauma is not mentioned in that.
Yeah, we could not actually intentionally cover it because the presentation has actually going very long and we wanted to cut it short. Yes, so actually post-traumatic seizures are, even though a major cause of the epilepsy in our neurosurgical practice, the management per se is much more medical rather than surgical. So that's why we have restricted to those conditions where the surgical intervention is far more common.
Proceed.
Okay. Thank you, chairpersons, and welcome again to all the dear members, faculties here. To begin with, let me first of all declare that this presentation is basically, we are trying to balance between two fields: neurosurgical field who think everything can be cured with a knife, and epilepsy surgeon who thinks everything is an epilepsy. So that's why we wanted to make a very tight balance amongst each. And then what we have been trying in the last 4 presentations had been that, look, there's always an epilepsy component in everything which we see in our daily OPDs. We may look at a brain tumor, we may look at a infection, we may look at a hydrocephalus, but then sometime even after doing a surgical maneuver, surgical intervention, in these cases, patients do develop epilepsy after a certain time, and these are very chronic and that needs to be addressed. Now, I bring forward some things in my presentation here, which may be a little bit of brain tickling, and that's why we can actually invite more discussion on that. To begin with, I will just like to explain the term lesional epilepsy. This is not mine. This is from the literature. And what it says is recurrent seizure due to tumors, vascular malformation, infection, or congenital anomalies, either picked on imaging or histopathological examination, and which they say by removing or the lesion may cure a patient with epilepsy. And that's why I put it in italicized, because that's not always true. We may be hitting on some other target, the epileptogenic focus may be different, and that's why that needs to be addressed. And that's why lesional epilepsy, even though MRI have made our life very easy by bringing or highlighting the lesions forthward, sometimes we are misguided. We see a lesion and we jump upon it rather than exploring the patients in detail and working the patient in detail. And that's what we are going to talk about in the next few minutes. What we need to consider is whenever we consider a diagnosis of lesional epilepsy on histopathological examination, it's a retrospective diagnosis. We may not have got it in the MRI, nothing. It's just because we have got did an SEEG or a subdural grades, and we have done some video EEG, and we have localized a lesion. And then we excise it and you find there's a FCD sitting inside, or there may be some other pathology there. So there's a retrospective diagnosis in that condition. Yeah, and also in focal onset epilepsy, even though the word is focal onset epilepsy, even which recommended by the ILA this time, not all focal onset epilepsy will have a lesion inside it. So MRI may be negative. So that is something which we need to consider. And now with the advent of the fresh electrophysiological modalities of investigations like invasive or depth electrodes, we are able to localize those lesions which are absolutely MRI negative, despite of doing repeated imaging. And hence for that brings forward a point. Are we actually talking about lesional epilepsy or something else? Should a new term be there? Initially, if you remember, ILE had recommended a term known as localization related epilepsy. Now, the problem with that terminology was that most of the diagnoses were idiopathic, and henceforth that there was no treatment for it, no surgical treatment available for it. So that's why a new term may be suggested, and this is just my thought process. I may be wrong. Maybe something like localizable epilepsy, where we could actually localize the lesion not only on MRI, but also on depth electrodes or invasive monitoring, and then try to hit on the diagnosis or the treatment of the patients. Now, if you see the classification of the lesional epilepsy, again given by literature, they have divided it according to the place of location, temporal, extratemporal, or subcortical lesion epilepsy, and then they have identified various pathological reasons for it. And there may be another component known as catastrophic epilepsy, which is seen in hemimegalencephaly, diffuse cortical dysplasia, Rasmussen's, or porencephalic cyst. Now, these most often are surgical conditions, and henceforth they need to be discussed in terms of a lesional epilepsy. And a simple classification could be congenital and acquired. Now, why does it matter? Because when we talk of epilepsy surgery, there's a gamut of procedures one can perform, ranging from lesionectomy, which most of the neurosurgeons perform on looking on a brain tumor or AVM or any vascular malformation for that reason, to tailored resection, to something known as hemispherectomy or disconnected surgeries. Now, it all depends upon what philosophy we are taking in these management protocol. Are we trying to remove the lesion only? Are we trying to remove the epileptogenic zone? We are trying to block the seizure spread. We are trying to block the disease progression, or we are doing a functional intervention in terms of neurostimulation or a neuroablation. So these all things are there now in the armamentarium of an epilepsy surgeon as well as a neurosurgeon for that matter. But then it requires a lot of detailed workup rather than just sitting in OPD, see an MRI and just take the patient to the theater, because there's a lot of things to be done. Now, I just share with you two experiences here. This is a patient who had a left temporal grade 3 anaplastic ganglioma, recurrent seizures for the last 3 months. We had operated him and then we did an anterior temporal lobectomy and amidocular hippocamectomy, and the patient got the Engel's class 1 result after the surgery, and he was now followed for the last 4 years. Then another case of a 9-year-old kid who had a left hemisphere encephalomalacia presented with recurrent seizures, intractable ones. And we did a perinsular hemispherotomy, and the patient could be decreased to level 2 in this patient. So when we're talking of a palliative procedure or a curative procedure, it cannot be done in every patient. There are a lot of things which decide, and the most important thing which decide is the cause and the location. And that's where the lesional thing or the MRI thing comes into picture. Now, I will just like to share a recent meta-analysis which was published in Medicine 2019, where they have pulled all the patients who have been started with antiepileptic drugs, the patients who have been freshly diagnosed with epilepsy, and they found that almost 25% patients had a drug-resistant epilepsy in their cohort. And when they're trying to find out the reasons behind it, the major reason was again a symptomatic etiology. So there was a lesion sitting inside, and that was not managed in time. Or the treating doctor must have thought that the lesion may not be too much of importance. So that's why he kept on treating the patient, and the patient develops a drug-resistant epilepsy. Now I'm going to tell you the effect of delaying the treatment also in the future slides. Now, another topic which I want to, or rather the work which I want to share is this meta-analysis on the surgical patients. Now, this surgical meta-analysis was on 40 articles, which was published since 1995. And then they have group 2 patients, non-lesional epilepsy versus lesional epilepsy. And they found that the patient who had lesional epilepsy have 2.5 times more chances of getting cure of their epilepsy. So this means we are going to have a better results if we are going to find out these sort of patients and try to help these patients out. Now, why this happen? Why there's a difference between a lesional epilepsy and a non-lesional epilepsy? Why this is the change or the difference in outcome? Now, it has been seen that the cortical lesion is substantially very much nearly located to the epileptogenic zone. And that's why trying to remove this cortical lesion, somehow we are trying to remove the epileptogenic zone altogether. So that is maybe helpful. And that's why it actually gets us to a more effective resection. Similarly, when somebody sees a lesion on the MRI, patient jumps on a treatment faster. So chances of delaying the treatment for a later period is far lesser in those patients who have a lesional epilepsy as those patients who have non-lesional epilepsies. Similarly, in non-lesional epilepsy, there can be multifocal seizure onsets. The failure of the scalp or the intracranial AG to pick up those signal changes. So this may also lead to the failure of diagnosis at the proper time, and the treatment could not be given at the earliest phase. The dilemma is that, as we have already spoken, Dr. Panta was also speaking about it, sometimes the lesion may not be near to the epileptogenic zone. The epileptogenic zone may be located far off from the tumor. Now, these are the patients which we get easily missed whenever we are sitting at a neurosurgical OPD and looking at the patient at in the only angle or the viewpoint of a lesion presented in MRI. So whenever patients present with epilepsy, the patient has to be managed as an epilepsy patient rather than a patient with a brain tumor or vascular malformation. Now, this is, I think, first one in of its kind publication from Cleveland Clinic, a 20-year-old longitudinal analysis of all the patients they have taken for surgery for epilepsy. And what they found that over the 20 years period, there's almost a 58% recurrences in the results, even though these were the people who reported best results in the first 5 to 10 years of their epilepsy surgery results. After 20 years, they find almost 58% recurrences. And they did a very extended analysis on this. This was published only in 2020. And what they found is almost 55% patients, they could not explain the reason why the patient had the recurrences. And that's why only a very small set of patients, that is 12.3% patients, underwent a reoperation for their recurrent seizures. Incomplete resection was found to be only 8.8% patients, and those were a minute of those. I think only 3 patients in the whole series were having a dual pathology for this particular reasons. Otherwise, mislocalization was there in 36.3% patients. So that means a lot of work need to be done, even though they have worked up most of the patients in the first surgery itself. So they have actually concluded that the first surgery is the best attempt one can make to control seizure if in case you are targeting the patients for a cure of epilepsy, for the lesional epilepsy. So the first surgery is the best, because even though you may get a good control after subsequent surgeries, the outcome ratio is not that high. So the first surgery is something which is very important. And they also have highlighted a new term that is known as surgical refractoriness, which they have said that maybe because of those 55% unexplained conditions or cases, there may be a scenario where the patient have developed a surgical refractoriness because of the long duration of seizures, and that's why the clinical phenomenon and a lot of this thing have already occurred in the patient. Now, that actually brings up to this point of concordance. Whenever we see a patient with a lesion, with an epilepsy, we should always undertake the first line of a first phase of evaluation as we do an epilepsy surgery. That is, we need to have a concordance with the semiology of the patient, that is the ictal semiology of the patient. We need to have a concordance of an interictal EEG. Now, this is very important in our place in Nepal, because most of the EEGs only report whether the report is abnormal or normal, rather than localize the disease for us, because if in case a localization is given in straightforward, it becomes easy for us to discuss also on that particular line. Ictal onset EEG, which can be picked up on a video EEG by admitting the patient and then monitoring into the electromonitoring unit. Of course, the MRI needs to be discussed with the radiologist as well as the neurologist in the same room, sitting in the same room, so we can have a lot of ideas forthcoming. And of course, neuropsych evaluation is very important to see what all deficits are we going to see in future after the patient underwent surgeries. And if in case the concordance is not there, we should go ahead with this level 2 studies. So in terms of metabolic studies like PET or ictal SPET or SysCom. So this is just a table of epilepsy surgery, which we all know. But then what point we need to make is that surgery for a surgically treatable lesion with epilepsy is an epilepsy surgery. So as rightly pointed out by Dr. Pant and Dr. Pravesh, we should actually take these cases as epilepsy surgery rather than a simple excision for brain tumor or a vascular malformation. We are actually dealing with a completely different condition. So how to suspect a lesion epilepsy? That may be happening to everybody of us. We may be sitting in OPD and a patient comes to us with a seizure episode. So should we evaluate the patient with our imaging? Now, these are the certain things which again have been highlighted with most of the researchers. Partial onset seizure and history or EEG or occurrence of a status epilepticus demands an imaging. So whenever you have this type of cases, you should always get a MRI at least. And also get a new, if in case a patient has a new onset or a progressive neurological or neuropsychological deficits or features of raised ICP, then again demands an imaging. Repeated seizure despite proper doses and compliance, that is intractable seizure. Patient is having a change in pattern or severity of the seizure. The pattern on the EEG is changing. If there's a relapse after initial remission, or if in case there's a generalized seizure which appears in the early years of life, that is less than 2 years of age, or an adult for the first time, this again needs to be evaluated thoroughly, because sometimes we be missing things. So before we start or change the treatment for epilepsy, look for the cause, and this is something which we should all do. Now, how to improve the diagnostic yield? neuroimaging for this epilepsy condition is very important because it not only detects the seizure, helps to identify a possible location of seizure onset zone, but also predicts and prevents deficits from surgery and also eliminates mechanism of epileptogenesis. MRI is always the first line of investigation rather than a CT scan, unless until there's an acute condition, we're thinking of a vascular lesion or there's a calcified lesion, then a CT scan makes a sense. Otherwise, we should always go for an MRI. Now, there are 4 things which has been identified by most of the literature to have a high yield diagnosis. One is definitely the field distance, that is a 3 Tesla or 1.5 Tesla or 3 Tesla and higher. If in case you have a 1.5 Tesla, you should use a phased arrow coil around the head so as to increase the resolution of your images, as well as you should have an epilepsy protocol as to how you scan the patients on an MRI. Most of the centers who are doing an epilepsy protocol, they are doing even now a half-hearted epilepsy protocol. Now we will be discussing that also in the next slide. And also the 4th and the very important component is that these radiologists should be discussed by a dedicated radiologist who's involved in epilepsy care and should be discussed amongst the team members, including the neurosurgeon and the epileptologist in the room. Now, this is just a recommendation by, again, ILAE regarding what type of MRI you require for hippocampal sclerosis, and the second box is for other conditions. So in T1 weighted image, we need to have basically a 3D image. And then T2, at least in 2 different planes, we should have a thin sections, we should have a flare. Apart from that, DWI and DTI is a very helpful. DWI will help you to know whether this is a vascular involvement or vascular edema associated with not. SWI helps us to identify a bleed. Arterial spin labeling is a new, rather it's not that new, but even it's new for Nepal. This basically tags water molecule which is flowing inside the blood vessel. So that's why it is as good as a perfusion based images. So if you do not have a perfusion images in your place, you can actually ask for a arterial spin labeling on an MRI, and this can also give you perfusion images on your MRI. And of course, even with contrast, if in case you are thinking of a vascular lesion or a tumorous lesion. DTIs are something which are now upcoming. Why? Because they will help you to show the pathway, and the anisotropy between the 2 layers or 2 sides can help you identify or literalize the lesion. And it can also tell you about what type of language or motor or a memory deficits one can actually expect in these patients. So the other tracks like arcuate fasciculus, uncinate fasciculus, or IFOF, they help you to understand these types of anomalies or deficits in the patients. Now, this is just a slide to let you know what type of changes one can see. So this is a MRI of a status epilepticus patient. And usually we all know in a status epilepticus patient develops some type of vascular edema or vasogenic edema in the brain. And you can see there's a cortical thickening in the frontal lobe. This is basically a DWI image. And then the subsequent ADC shows restriction of the images. And then in the flare also, you have subtle different changes in hyperintensity. But again, when you do a contrast, you do see a very high uptake of vascular edema. So these type of different protocols, when you're using for epilepsy imaging, then help you to diagnose the condition much better. Now, this is a very important talk where I'm going to talk in 2 different slides. What is the role of repeated imaging? Now, this paper was published in Korean Journal of Radiology, where they have done a 15-year-old period study repeating the MRI. They have actually made 2 epochs, one with a 1.5 Tesla, the other one was a 3 Tesla MRI. And what they found is that repeat MRI actually reveals around 21% positivity, with almost 50% of the patients identifying an epileptogenic focus on MRI. And what were they finding out in this repeat MRI was focal cortical dysplasia, hippocampal sclerosis, polymicrogyria, heterotropic gray matter, microlissencephaly, cortical tumor. Now, these are all small tumors which are easily missed on 1.5 Tesla MRI, unless until you have a dedicated radiologist and an urge to see what is going in within. So, and then they found that almost more than 90% reasons for failing to identify was radiological, and they were actually comparing two machines, 1.5 versus 3 Tesla. Apart from that, these authors also said that if in case a person has got scanned less than 2 years of age, that is the age when the myelination has not yet developed completely in the brain, one should actually undertake a repeat MRI in these conditions. Now, this is just some small example now of a focal cortical dysplasia. You can see in this particular scan, there was a little bit of subtle cortical thickening, which was done at the age of 3 years. But then when the child's MRI was repeated over the period of next 7 years, the lesion became much more prominent. So FCDs or cortical dysplasias, sometimes they get picked up on a repeat imaging after a certain period of time. So one should remember that rather than just negating the MRI on the first hand. Similarly, this is an example how an improvement in imaging can help. So this was in 1.5 Tesla, this was in 3 Tesla. And you can see again the focal cortical dysplasia and the frontobasal area, and you can see this this is subtle thickening. It can be or cannot be, but it is very well evident on the 3 Tesla MRI on a later date. Now, this has also been shown to be helpful. Repeat imaging has also been shown to be helpful in adults with chronic epilepsy. And this was a study which was again done by over 804 patients. And what they have found that the change in diagnosis was made in 26% patients by repeat imaging, and which have helped them to identify 5% new lesion. One other thing which I have highlighted by this paper was that in chronic epilepsy, say for example, you may have seen a patient of a hippocampal sclerosis on a right side. What they have found is that over a period of time, because of kidney phenomena, because of various other reasons, hippocampal sclerosis have occurred in the other side also. So sometime you may see a burnt out condition. So you may be thinking in the first hand, a patient of a lesional epilepsy, put him for this surgery. The patient did not follows after 4 or 5 years down the line. The patient may have a complete different pathology going inside his brain. So that needs a further demands a further investigation. So this particular study actually highlights the need of repeated imaging in these conditions where we may be avoiding certain unnecessary surgeries in these conditions, which are bound to fail even with a circuit surgery. Now, all MRIs are not helpful. If you see the types of lesion one can identify based on MRI, these can be classified on 5 different types. There may be some non-specific abnormalities like periventricular leukomalacias, atrophy, never related to the seizures or epilepsies. There may be some static remote lesions like porencephaly or MCDs. There may be focal lesions. Now, this is something which is very important for epilepsy surgeons. There may be some focal lesions which are responsible for seizure, but do not require an immediate intervention. And the other 2 groups are subacute or chronic processes like brain tumor or leukodystrophies or metabolic disorders, or maybe some acute processes like hydrocephalus or acute stroke. So one has to see that these different types of lesions which appear on MRI, they demand a completely different type of surgical approaches. So that's why we have to be cognizant of this fact also. Now, if in case MRI is negative, despite of repeated imaging and everything, do not leave the case there and then. If in case you have identified it to be a focal onset seizure, one should actually again go and look back into the seizure semiology. Seizure semiology has a lot of good things hidden inside it. It will not only help you to localize the lesion, but also have lateralizing value. And it has been shown in studies that these types of seizure semiology are at par to interictal or ictal scalp EEG and MRI in certain cases. So that's why ictal semiology has to be worked up in all the patients, even if in case the MRI is negative, to go back again and look into these scenarios, or they may demand an invasive monitoring in these cases where we need to undertake an invasive monitoring to find out the focus of the epilepsy. Now, my previous speakers have already told certain types of risk the surgery puts the patient on of seizure, and definitely that's true because in animal studies, generations of free radicals, imbalances between the ions as well as release of excitatory amino acids have caused post-seizure, post-trauma like operations or post-surgical seizures. So that's why all these operations, so neurosurgical procedures done on a patient, they are considered equivalent to a post-traumatic seizure in terms of the time course. And that's why ventricular shunting or patients with intracranial tumors or AVMs for that matter needs to be followed for a longer period because they may not show a delayed seizure on a later date. Now, we all practice that 7-day protocol, but that was basically also my understanding that 7 days is something which has been proven by some guideline or supported by guideline. This is just to share with all of you that this particular guideline, which was given by ILAE, is now been, American Academy of Neurology has now been retired. So if in case we are using those 7 days prophylaxis protocol for perioperative care, this is a retired guideline. A new fresh one is being made, but in the website of AAN, they have said that this particular guideline is retired. So that's why this is just to share with you all that if we are using any antiepileptics as a prophylactic drug for any of the lesional epilepsy, it has not been shown to have any prophylactic role till date. So whatever we are using is just for our own clinical practice to keep us ourselves safe. So this is just a synopsis of what Dr. Vidur has already told, so I'm going to skip it. There are certain surgical measures to achieve good epilepsy outcomes. If, for example, use of perioperative steroids, because it helps decrease the vasogenic edema, so it helps decrease the chances of seizure and henceforth epilepsy on a later date. Intraoperatively, use of ECOG is a very, very vital thing, particularly if in case you are thinking of a dual pathology or a remote sites of epileptogenic zone. Bloodless field is something which we all like to maintain to avoid seizure in the post-operative phase. So that's why we should need to irrigate the field of the clot and the foreign bodies after this surgery. Hydrogen peroxide and cautery are something which we are also using in most of these scenarios whenever there's a lot of bleeding, but then mind you, this can cause post-operative seizures. So that's why this has to be used very carefully, minimal cauterization. And if in case one is using hydrogen peroxide, always use it with a cottonoid soaked in it rather than spraying the hydrogen peroxide over the brain directly. And then, of course, the follow-up parameters like doing and interictal EEGs in the follow-up is very important, because sometimes this may help you to predict these seizures. But even though I'm saying so, the evidences are not completely in favor of it. There are various evidences which show interictal EEGs cannot predict the occurrence of seizure in the postoperative phase. So even though there's an issue on this. Now, there are certain favorable outcomes and non-favorable outcomes, which we have already discussed in detail. Now, what's new or developing in this field of lesional epilepsy is the gamut of investigations which are now available with us. MEG, even though it's not available in Nepal, it's very much available in India, in Delhi and Mumbai. So if in case if one of the patients requires MEG, they can be referred to these places. MEG actually helps us to pick up the magnetic dipole which is generated during the seizure event. The problem with the MEG is that it does not picks up the deep-seated lesion. It will only pick up the superficial. But the best part of the MEG is that it gives you a very good spatial resolution as compared to the EEGs or source imaging using an EEGs, which are very good for temporal localization rather than a spatial localization. Similarly, PET and SPECT are metabolic-based tests, which Dr. Shah has already highlighted earlier. And then high frequency of oscillation are something which is a now upcoming thing. High frequency oscillation is very good to pick up the ictal onset zone. Why? Because it has been shown that even after the patient has gone into a frank seizure, unlike the EEG, which gets actually bizarre after the patient have a seizure, the HFOs remains intact. They do not get obliterated. Henceforth, even in case of a network-based epilepsy, HFOs will be able to help you to pinpoint on the focus. And then stereo EEG is something which is in thing. Centers in Nepal have been doing it, and we have recently bought a robot also to put an EEG electrodes. The idea was to get in Visualize, but then there's a lot of administrative hurdle for it. So Visualize is a laser ablation using the pathway which has been identified by SEEG to ablate the networks and then inside the brain itself without opening it up. So Visualize is a very good modality, particularly for the brain tumors as well as for the epilepsy. So these are the new things which are coming up in lesional epilepsy. And then just to have a concluding talk on this, so we will just avoid by what Luder and Awad said in 1992. The whole idea of epilepsy surgery is to remove as much possible as presumed epileptogenic zone with a minimum of neurological and cognitive deficit. So this is slightly different from what neurosurgeons do for tumors. That is the safe maximal excision. In this epilepsy surgery context, we actually do a safe excision of the epileptogenic zone as much as possible. And of course, this concordance table is something which you all need to follow. Before I conclude, I will just like to put up this slide from Usual et al. In 2012, which is also relevant in our context. Substantial underutilization of surgery as a treatment of epilepsy has been seen all over the world. Even in the developed countries also, the surgery as a treatment of the epilepsy is being underutilized. And that's why surgical evaluation must be a priority role in all the refractory patients. So to conclude, lesional epilepsy is an evolving concept. As we are looking at through the duration and pulling up a lot of new investigations coming up, maybe we will be not talking of lesional epilepsy only in terms of MRI-based finding, but also a lot of other things which will be picking up lesions in days to come. Long-term outcome is much better than long-lesional one. There's no denying this fact. Suspicion is the key. So unless we do not have a very high index suspicion, go back to the patient and look for it. We are not able to hit on the diagnosis, and the chances of missing on this particular element is very, very high. High quality cranial imaging is always a yes. So repeat if needed. However, a non-lesional MRI does not negate surgery, and surgical approaches need to be tailored. And also follow-up electrophysiological studies are very, very important, which we as a neurosurgeons are doing lesser often. So that's why we have to do these things as much as possible. So with this word, I would like to say thank you for your patience listening, and invite any questions in the end. Thank you.
Thank you, Amit, for a very nice presentation and adequate in a very short time. And now we think we are also getting late, so we should go for the discussion.
Thank you very much for the nice presentations. May I have your attention that in epilepsy, the MRI protocol, which we always write epilepsy protocol, but the radiologists include T1, T2, and FLAIR, and the coronal, and sometimes GRE, that much. Now, what happened that in 2019, the ILAE has suggested that uniform protocol should be followed in patients with epilepsy for MRI. So they have proposed a harness epilepsy protocol, harness MRI protocol. Yeah. Anyone radiologist from and the audience know this or have practice or not? This harness MRI protocol in epilepsy. That means harmonize neurology, neuroimaging of epilepsy structural sequences. That means harness MRI protocol in epilepsy. So it includes sequences like, there are 5 sequences, the 3 is mandatory and 2 are optional. And the first sequences is magnetization prepared for gradient echo, that is T1W. And the second is 3-dimensional FLAIR imaging, that T2W. The magnetization prepared for rapid gradient echo gives a very detailed and magnificent anatomical detail of the brain structures and morphologies. So that is mandatory. And the second is 3-dimensional FLAIR, fluid attenuation inversion recovery imaging, T2W. So that gives the T2 hyperintensities, and that very nicely it points out the cortical hyperintensities, and very small pen lesion also will be very nicely seen in that. And the third is, that is also mandatory, high in simple resolutions, coronal 2D, 2 dimensions. So that gives a magnification and very beautiful structural details of the hippocampus. So that is done perpendicular to the hippocampus, the high resolution is done. So these 3 are mandatory and the 2 are optional. If you suspect the tumor infection of vascular etiology, then you can go to the gadolinium enhanced T1W, and the fourth is the SW1 or T2 squared W imaging, which is used for hemorrhages and calcifications, hemosiderin, and in vascular, in the venous blood. If you think that there is a tumor or infective pathology or vascular origin. So this protocol has been suggested, and in the American and the Europeans are following this protocol. So I do also suggest that we should use this protocol, harness MRI protocol for epilepsy, so that will be better. And other thing that what I would suggest that in somewhere in our sphere, that there should be comprehensive epilepsy center where everything could be done. You see, if you think that this is refractory epilepsy, by refractory epilepsy, which we mean that 2 drugs, anti-epileptic drugs administered with adequate dose and with the patient's tolerability and the seizures and the syndrome, which has been quite defined. And if that is not responding, then trying another more drug will not be effective. So there are more than 20 drugs available for epilepsy treatment. So the neurologists or my friends will try to see that these 2 are not working. Let's try the 3rd, 4th, 5th. But in practice, that if you try 2 drugs in a maximum dose, tolerable dose, having identified the epilepsy and syndrome, it will not going to work. So that should be a case for epileptic surgery, and those cases should be sent to the comprehensive epileptic centers where they could have all video EEG, and then MRI, then PET, SPECT, and if needed, intracranial stereo EEG, and everything that one. So that will be the best things to practice. This one. Thank you.
That's very true, sir. Basically, Dr. Pant is also here, the president of Nepal Epilepsy Society. We can actually write a recommendation to all the MRI centers working in Kathmandu and outside the valley to use a homogeneous protocol, which we have just mentioned and talked about in all the epilepsy patients. The moment we write the epilepsy protocol, that should be done in all the patients.
Any question or queries from the audience?
Thank you, Dr. Amit, for a very nice
There's no question
presentation.
from the Zoom yet.
So my question or query about epilepsy is like more you understand is fast. So maybe as you have presented in your slide that diffusion tensor imaging is also coming up. So nowadays 3 Tesla MRI, we can see the tracks. Last time we were also discussing that might be in epilepsy surgery, we are not taking into consideration about the tracts. It's basically the tracts from where the seizure arises. So like in neuromodulation, that is the anterior thalamic devious or BNS, that is the modulation of the tracts that hinders the seizure for non-lesional epilepsy. So once we start doing DTI in seizure cases, then we will be able to understand it because we are in the primitive phase of DTI. But with this new technology, with 3 Tesla MRIs, if we can integrate this in the near future, we can even more better recognize the etiology. Thank
That's true. That's true. Very true. Basically, I was surprised to know that when we were talking DTI, we think DTI is only one modality, which may be done by only one method. But that's not right. What we are doing right now as DTI in our place in Nepal, it's very primitive. The chances of leaving the track, particularly where the tracks, they cross each other, they lie one after the behind and the other, they can be easily missed. So now there is a new thing which is coming up and we are trying to get in Nepal also, maybe by month of August or possibly September, we'll be able to get that. That is known as connectomics. So most of you must have heard about this connectomics. So in connectomics, they are using a machine learning method, AI method, by which they are actually going to identify these DTIs much better. So the DTIs which are available on navigation system, including Brain Lab and the Medtronics, they're also working on the old principle. The connectomics is the new thing which has been shown to have a very good pickup rate on the DTIs. And they are coming with a new software, maybe in 2023 for epilepsy and for functional neurosurgery. For now, they have been FDA cleared for brain tumors. So connectomics is the in thing which is going to help us a lot in identifying these tracks much better.
Anything from the Zoom audience?
Sorry, I didn't see any questions right now. Dr. Bikesh Kambu says we more think of a lesion cure rather than seizure with lesion with seizure, that is controllable epileptics. So that is the whole thing which we're talking about.
Dr. Amit, I have one question.
Yeah, Dr. Gupta.
Sir.
Dr. Gopal is asking something.
Thank you, Dr. Amit and team KMC for a good presentation. My basic question is, many of us are doing intraaxial brain tumors with seizures. And should we treat it as a epilepsy or should we treat it as a tumor? I mean, should we get EEG in every patient? Should we do just a lesionectomy or involve all the part that is involved in each and every intraaxial tumor?
So after listening to all this talk, what do you think? No, I'm just asking because it depends upon like the way we have presented, because it's also a learning point for me. If in case we have been able to push this message across, this is success. Otherwise, I've just come on this stage and talked for nothing. So I'm asking, what do you think after this talk? Did I make sense in saying that?
It's very difficult to do it like an epilepsy surgery in every patient. It's very difficult.
So what I can actually tell you is that
but if we can tailor it in such a way that we can do both.
That's true. So basically, thank you, Gopal, for raising this question. This is a very pertinent question, and most of us sitting in this room or listening to this talk may have this particular feeling, because not everybody is blessed with good neurologists in their center. Especially at KMC, we do not have a single neurologist at present. So not every center will have all the protocols which you have just discussed. So that's very true. But then when we were talking about epilepsy surgery, there's always a thing known as phase 1, phase 2 studies. So we can actually do a phase 1 studies at our own places. So phase 1 studies means nothing. It is just like it's looking at the seizure semiology, looking at the interictal EEGs. And if in case you have a video EEG possible, look at it and then try to have a concordance with that MRI. So this is very much available to all of us. And we can request our neurologist friends to give us in the EEG reporting, the interictal EEG reporting, to just help us to identify where the lesion, where the interictal epileptiform discharges are coming from. So this can also help you make an idea as to where the lesion is, at least literalize the lesion for you. If in case it's not able to be localized, but literalize the lesion for you. And if in case it is literalizable, then one can go with just this level 1 study ahead. If in case there's a discordance, or if in case you find there's a patient is having a neuropsych evaluation, in that case some deficits, then you should go for a level 2. And if in case you think there's a level 2 evaluation which is required, please do not attempt these types of surgeries at your place. One should refer it to the center where all these facilities are available. Or you can ask an expert to come to your place and help you out.
Let me give my opinion on that. I don't think anybody can answer your question, which is pretty difficult. But our experience says, let's look at the natural history of epilepsy first. So I think this came in the presentation also. So if you think it is a intractable or a very difficult sort of epilepsy with tumor or a vascular lesion or whatever, then you need to treat two things. But if it is, let's say, somebody presented with a seizure and then you saw that there is a tumor, then I don't think epilepsy is a major issue here. It's only tumor that you deal with. So why we have epilepsy? Epilepsy is because of two things. One is because of chemical changes, okay? Chemical changes do not cause long-term epilepsy. Like trauma, you have, within 24 hours, you can have seizure, that's a chemical change. Or within 7 days, that's a chemical change. But if you have a seizure after, let's say, 6 months after trauma, or 6 months after, brain surgery, then you have a structural damage. And there is an epileptic zone there. So it's a totally a different game, in that point, then you have to think of epileptic surgery as well as tumor surgery. Okay. So this is my idea.
It's just, no, sir, it's just the same thing. Yeah. Basically, what Mansar is saying that we have to look at the intractability of the seizure. If the patient is having an intractable seizure, then it becomes an epilepsy surgery. So we have to go for a phase 1 and phase 2 sort of evaluation, or else we just maintain it as a lesional and then we can go ahead.
Thank you, sir. And thank you, Amit, for highlighting all these few comments. You tried to cover all the lesional epilepsies. And what's important is tumors, especially DNAT and ganglioglioma. They are potential tumors which have got high epileptogenicity. So any patient coming with DNAT and ganglioglioma has to be worked up from the beginning, because this is a potentially treatable cause. And if any neurologist or neurosurgeon come across, the case has to be evaluated from the surgical point of view, and has to be evaluated properly, and epileptic surgery has to be done for this. And because the thing is, there is a tumor, and then sometimes there can be associated cortical dysplasias sitting with gangliogliomas. So we need to look at the picture as a whole. So that's one thing. The other is you have a nice case of cerebellar tumor presenting with seizure. So previously we used to think it's mostly the cortex which is responsible for the seizure, but now the epileptogenesis has come. The hematomas, hypothalamic hematomas, they are subcortical, but there is epileptogenesis. And similarly, in cerebellum also we get seizures. So we should not be thinking that unlikely to have a seizure. Even in this, most of the cerebellar cases can come with seizure. So we need to evaluate them again and treat them properly. And I agree, the team has to be there while treating a patient with epilepsy. It has to be a comprehensive epilepsy workup, including the neurosurgeon, neurologist, psychiatry, okay, and then the radiologist sitting together and discussing any patient which you are taking for the epilepsy surgery. I think that culture we have to set. Thank you.
Anyhow, very good discussion. I have one not query, this is just a, if we do a infective surgery, the cerebral abscess, after the cerebral abscess, there is about 60%, 50% chance of the epilepsy that's true. After the surgery, there is persistence of the surgery. So chances are two, could be the gliosis or could be a different epileptic zone. So how do we proceed in such case?
Again, we come back to the same thing which Pandasa has been saying. If in case there's an intractable seizure, then we have to look for the focus. However, in the infective pathology, if in case it's a focal pathology, say for example, as the point you're trying to make out, it's a meningitis or it's a cerebral abscess, then that focus can be identified. Or before we go for intractability, we have to try other medications also at the same time and see whether the intractability can be actually done away with some change of medications. So medical, once we have tag the patient as medically refractory disease, then there's no role of medication, and then we have to go for sort of see whether there's a focal pathology which we can do cut away or do disconnective surgery. If in case that's not feasible, then there's something which we have known as stimulation or an ablative therapies, right, which can be done through RNS or VNS systems. So we can also cut down on the frequency of the seizures by those conditions. But then it's very difficult question. Sometimes the disease pathology may be very diffuse. Say, for example, ventriculitis. A patient's having seizures because of ventriculitis. So ventriculitis has actually involved a large part of the ventricle wall, and that's why there will be many seizures focus. So it's not very easy. So in those cases, rather than curative resections, one can go for a palliative ones. But then this is a very difficult question to answer.
Why I raised this question? Because the paper was presented in Hong Kong from a AIMS guy, and what it is, after the excision of the abscess, there was a scar or gliosis, whatever you call, and then he operated persistent of the seizure. Then he operated upon that, the scar or gliosis, and that used to bleed the money. I mean, stop the seizures or decrease the seizures. So I could not understand that at that time. Of course, it is a 15 years back, which I attended the meeting. But is there any answer to that? Epileptic zone is different. It's very true. But how the gliosis removal can stop the seizure? That I could not understand.
So in that case, maybe there was a focus which was basically the gliosis. This may not happen in all the patients, but in that case, maybe that is the scenario which has happened. And that's why once he did a surgery, a resection surgery based on the focus which has found, he got a good result. But then again, after looking at those 20 years result from Cleveland Clinic, I'm still doubting what all we are operating as the lesions, as a non-lesional or whatever we can give a name, focus surgery and everything else. Patients do recover, 53% recurrence over the 20 years. And that too in Cleveland Clinic, which is known to have the best team to work up a patients completely holistically. So they have 53% recurrence, means epilepsy is just not a focus.